morning, everyone. Actually, it's not my turn to speak. Today, Dr. Andrea is supposed to speak on this topic, challenging implementing antimicrobial stewardship in Asia. This is Dr. Andrea. Can you get up? Dr. Andrea is a clinical pharmacist trained in College of Albania, upstate New York. After her uh, training, she continued to practice clinical pharmacology with expertise in pharmacokinetics and pharmacodynamics, and she is very integral part of the antimicrobial stewardship program in the country Singapore. So she is a very well accomplished, highly continuing to do the educational activities, a lot of research programs she is seeing and trying, means she is having a very good teaching program, teaching and training program across Singapore and outside Singapore. So she is a very well accomplished person. She has gotten she was part of the surveillance which is carried out as part of the antimicrobial stewardship program of this Pfizer initiative. And whatever the finding which we obtained through this questionnaire-driven surveillance survey, she was part of it and she has wrote this manuscript. And she has done all these slides. Since this morning her voice is lost, I am acting like an his master's voice, HMV. So I'll be presenting her slides. So this is the paper which has been published on the finding of our observation, that is gaps in antimicrobial stewardship program in Asia, a survey of 10 countries. So why we would like to present this antimicrobial resistant or the antimicrobial stewardship gap in Asia is, it's almost 95 to 100%. It's a problem of antifungal stewardship also. So there won't be any change, there is any difference between antimicrobial stewardship or antifungal stewardship. Let's see what is the reality in every country where the gap is there, where our understanding or our commitment is lacking. So look at this one. Why AMS for AMR? The first and foremost important is antimicrobial stewardship is a coordinated set of intervention designed to improve the appropriate use of antimicrobial agents. This will lead to reduction in the cost, reduction in the AMR development, and the improvement and the early discharge of the patient will occur. So for this reason, antimicrobial stewardship has to be implemented in every hospital. And to carry out that, we have identified a set of core components. This core components, you fix it, then the program is good enough. So what are all these core components? I will explain you in the subsequent slides. So we want to see whether these core components are there in place and it's practiced in each and every hospital. So these core components, to briefly mention, this includes support from the hospital administration, available of the AMS team, and whether they are having a plan of implementing this, and a structured reporting system, adequate hospital infrastructure. These are all the core components. And why we have to do this surveillance? Because there is an inconsistency across the countries and the regions. And there were lack of core components. The identified 12 core components were missing in many places. If it is missing, then a simple one link missing in the chain weakens the entire chain. So we want to make sure that every component is in place and it is functional. So these components we have identified and we have looked for that one. And then what we have done is we have analyzed this and we have come out with the observation. So what are all the methods we have followed to bring this information is, now we developed, after a long brainstorming deliberation, lot of questionnaires and identifying the component. The questionnaires included hospital, location and level, tertiary care, secondary care, remote, urban, semi-urban, access to the medical care. Then hospital leadership and their commitment, and a safety culture as part of their hospital culture. Then whether they have antimicrobial stewardship, whether the stewardship committee had a qualified person in the team who are knowledgeable and have competency to teach, train, educate the juniors and supervise the juniors. Then monitoring and reporting of the antimicrobial strips. They may carry out well, but are they continue to monitor and are they reporting it? And hospital infrastructure, continuing medical education in antimicrobial stewardship, and what are all the challenges they faced and how they have dealt with the challenges. These learning lessons. So these are all we have collected. And this is the next two slides are the most important slides. I am giving you the core components which we have identified and asked them whether they are doing in place and they are practicing. One is commitment from the administration, country or the institution. Then they may have committed, but have they allocated budget for it? That is the second component. Third one, whether there is a competent leadership to spearhead the program. And these are all the advocacy or policy. Then the antimicrobial stewardship team per se, the physician or the infectious disease leadership, supported with microbiology and clinical pharmacist, and equally with the infection control program implemented in that hospital. So these are all the four components, and you know that there are many other accessory components are there. I don't want to dilute by including all those things. These are identified as the core component. Then we move to the other functionalities. So there are very important certain documentation or functions of the antimicrobial stewardships I've gathered. One is facility-specific antibiotic guideline. If it is a transplant unit, neonatal unit, surgical intensive care unit, or medical intensive care unit, burns unit, and surgical prophylaxis. So for all the important, based on the hospital and the unit, specific guidelines, presence or absence. Then most important critical component, that is prospective feedback and pre-authorization, which is identified as very important, and evidence-based benefits are derived from this pre-authorization and prior authorization and feedback. So this is called as low-hanging fruit, and everybody practices whether that is available. And do they have intervention program? Because they may identify, may they do, but if something goes wrong, are they intervening? Are they allowed to do the intervention? And apart from this, to strategize and to implement the continuous improvement in your practice, are they developing and reporting cumulative antibiogram and total antibiotic consumption in the hospital or the region, and the way it has to be reported, DDD or DOT, and similarly cumulative antibiogram should be in the proper way, and how they monitor and how they give the feedback. So these important components were included in the questionnaire. And how we have done the analysis is either yes are collected together, no were collected. When it's not applicable, we have excluded that. And country-wise, we have calculated, and overall all the countries put together as a continent we have calculated. And the proportion of hospital-facing challenges were calculated based on the total number of response, and the blank answers fields were excluded. And we given special emphasis for all the 12 components. So I will be showing the the assessment for the 12 components a little later. This is how we have analyzed. And each country lead of the antimicrobial stewardship group took the initiative. They have distributed the questionnaire across their country, and they have collected the answers and handed over to the central team. You can see various country response, the distribution and the response received are given in percentages. Certain countries could get the feedback in very limited numbers, whereas many countries could get up to 80, and few surpassed the 80 response they could get. Very few had very limited number of survey answered. So with this distribution, collated data, we have seen that overall 59% of the responding hospitals proved tertiary care level are the one who are responding. because they had better clarity and understanding than the secondary care and the primary care. And most of them were private hospitals than the public hospital. And in certain countries like Indonesia, highest proportion of private hospitals responded. And even India, it's the same story. And Malaysian respondents were predominantly from the public hospital, while Vietnam responded only the private hospital, public has responded exclusively. Another interesting information we gathered from this survey is more than 57% of the hospitals had more than one ID specialist. Means the question was answered basically from the uh, elite hospitals. It's very clear because they are the one where very well informed and they are taking care. That's where the antibiotic usage was very high and antimicrobial resistance also very high. So they were forced to practice. That is one way of interpretation. Another one is they are also very well informed who had a good clarity of the thought and understanding. So that's how the response have come from those group, and the response were very limited in the other group for the simple reason their clarity, understanding on the knowledge and the skill for practicing AMS were minimal in the other centers. So that was the important gap has been identified during this survey. And many people, the ID people were in charge and they were doing the AMS in certain countries. Whereas in certain countries, apart from ID, even the physician had taken over the role of antimicrobial stewardship, practicing or the leadership. So there is a huge difference felt between the countries. And most of the answered hospitals had a good microbiology lab and infection control practice. So definitely that, and we can understand it goes in tandem with the ID physician being there and practicing. And this is a big table, but what I would like to say is all the green are positive response and the black are negative response and overall. So the finer information we can derive from the table is wherever black is there, there you can see that it's a negative response. One example I would like to say is look at the 12 components, the first row. Almost all the 12 components are not fully followed in any of the country. So only 13% where you can see all the 12 components are in place and practiced. So it's very suboptimal and there is lot of gaps in every country. Second one is financial commitment from the hospital or the region or the administration or the government. Definitely the commitment is there, awareness is there, but it doesn't reflect in the financial support. There you can see lot of black. So it's not in the green. So they agree, but they don't support financially. So again, there is a gap. And physician leader, where general medicine also takes care of the antimicrobial stewardship in most of the countries. In certain places, they leave it to the ID physician to do. And in many places, ID is integral part of the antimicrobial stewardship. In certain countries, it's not happening. So this kind of breakup of the details. Here, I'm not worried about the numbers. It may improve, and there is a lot of chances for improvement, and it's a dynamic process which you need to do continuously. What I am trying to highlight here is understand the component and its importance and its function. So that's more important. Then you can see the pre-authorization and the feedback. In certain countries, it's not happening. Then in many places, the guidelines are not in place. And so on and so forth, you can see there is hospitals, infrastructure is poor, micro labs are not accredited. So there are many components which we have identified as part of this questionnaire. So here our primary job is to identify the component and create an awareness and help them to simplify the process of following that component. That's what we try to achieve with this process. So this is the result now. And I would like to draw your attention on certain components. Of course, nothing is 100 out of 100. There is a fall in certain areas, but drastic fall where all we have seen is, number one is where there is a lot of improvement required is funding. You need to appoint the expertise in that area who works around the clocks and make sure that antimicrobial stewardship is followed. It's an one person full-time duty. So for that, a person needs to be appointed, salary has to be given, and he has to be trained continuously. He should have knowledge and competency. So that's just lacking in many. That is the first and foremost. If there is a no person to teach and train, then how can change the scenario? It's not going to happen. And second one is, look at this one. Many people, in many centers, the pre-authorization or restriction to use of the last resort antibiotics are not at all happening. That's very important to retain the effective antibiotic. That's not happening. Second one is gathering the feedback. Again, that is not happening because without feedback, you cannot tailor your strategy. So feedback is essential. So pre-authorization feedback, it's not happening, which is identified as one of the key component for antimicrobial stewardship. That is missing. That is missing to the lowest percentage, 66%. And third important one is, does this hospital monitor the use of specific antibiotics, antibiotic prescription? So that is another important data which we need to have for antimicrobial stewardship. You may have a guideline, you may have an antimicrobial stewardship. The key performance indicator to know whether the cumulative antibiogram, antibiotic policy, standard treatment guideline, and antimicrobial stewardship are followed should be reflected in the antibiotic usage prescription. If it is other way around, that tells you that none of these components are working. You have standard treatment guideline in the place, antimicrobial stewardship practice in place, but the antibiotic usage is not reflecting. That means it's not properly being done. So that is another critical. Again, that is lacking almost only 64% is there. And people are not publishing. So the data, the prescription data, AMR data, and the clinical outcome data are the three important components which should be in the public domain, at least for the healthcare professionals to understand and to correct and streamline the process. So that's not happening. So these are all the critical components which we have highlighted in that paper. So where we need to emphasize more. So what are the other gaps is, they had AMS leadership in most of the places, up to 70%, but competency is again questionable. To best of his knowledge, he may practice, but that we don't want. We want expected the competency to be there. We don't want the best of his competency. The expected competency for antimicrobial stewardship should be there. For that, you need a PKPD information, cumulative antibiogram, prescription pattern, and then teamwork, collaborating, and cooperation from the other healthcare faculties, doctors, should be there. So just mere presence of leadership doesn't make any sense. So this is one component, but people are being identified as leader in majority of the places. That is the first thing to happen. Then thereafter it can improve. And pharmacist role has been appreciated in many countries, and 50% have as part of their integral team. And many people, they don't know how to de-escalate. And many centers, they don't know how to switch over from IV to oral. And many hospitals, still they continue to not to have the cumulative antibiogram periodically prepared and disseminated. Then certain hospitals are good at having the rapid diagnostic facility so that they can take an immediate appropriate drug prescription. So rapid diagnostics are very important. It can be simple lateral flow assay or with turnaround time very short, or molecular test. So certain places have realized the importance of that, and they are including that. And another important component we have identified is definitely antimicrobial stewardship can be improved using the IT systems. In many centers, they don't have a system for analyze the AMS data, or they have the system, they don't have the competency to do that one. And health records are not in most of the hospitals, and the prescription is not ordered through the system. If you have a prescription ordered through the system, then it becomes very easy for you to collect the data. If it is given manually, and they may tend to buy it from elsewhere, and you may not have the data. So that is one important point. And educational activity, the continuous education, what we are learning that needs to be shared and disseminated. So they have informal, it's there, but really it has not translated into effective knowledge and skill and implementation. Many places they continue to teach, but it's not mandatory. Certain countries make it mandatory and they certify. Japan and Taiwan, they certify that they have been trained for their competency and skill. Others they do, but they don't certify. So it's very important to certify them also. And when we have asked quite a few questions about the challenges, because this is more important, sharing the experience is more important. And many people, they could not answer this question about the challenges they faced because no, they don't have a clear idea. So they can't express it. Somewhat they have said, maybe they said, so very much a challenge they said. They could not explain in detail. Means they have not understood properly. This is another important slide. Look at that one. Many people told that they don't have clarity in the knowledge. They don't have understanding. So it's very, very important that we need to tell each drug where it is appropriate, how it has to be given, dose, duration, de-escalation, and system-wise it differs. So all the drugs cannot work in all the system. So in the respiratory, in the systemic, in the intra-abdominal, urinary tract. So those kind of thorough knowledge only helps them to effectively implement antimicrobial stewardship since they have not been taught in the undergraduation and post-graduation. In the later part of the life, when you ask them to learn, it becomes challenge. You cannot teach old dog new tricks. So that's what happens. So it should be part of the early undergraduate curriculum. And inadequate practice, staff concerns, lack of manpower, lack of information technology, lack of funding, and the staff resistant. Because surgeon doesn't want to stop the antibiotic when it's going is good. Don't rock the boat or don't change the winning horse. So like that, they don't want to change it to narrow spectrum. They want to continue the broad spectrum. So there is a interdepartmental or interpersonal problems may rise where they need to cooperate and fall in line. And you can see the administrative support is not there in many places, and awareness is also not there. And hospital policy, national policy, many things are missing. Actually, the WHO GLASS report to great extent has pushed the awareness, and they brought in at least some blueprint, whether it's functional or non-functional, but it is in place now. And there are a lot of limitations are there. We have not piloted and we have not included most of the realistic problems. To some extent, to overview only, we have collected this informations. And you can see primary, secondary, public hospitals have not reported this. And summary of the finding, you can see here that only 13% of the hospital had the 12 components in place and practicing. Majority, lot of gaps are there. Second, the commitment from the government or the administration is there, but it's not reflected in the funding. And third one is, another important, the prospective auditing and feedback was not happening. And hence, we are very sure that appropriate antibiotic prescription is not happening. And many people, they are not publishing their antimicrobial resistant data and on prescription with appropriate therapy, what is the outcome? If they don't have this clarity, it's very, very difficult to implement honestly the best possible antibiotic prescription. So I want to finalize in this last slide. So the most important gaps in the core component of the hospital program in Asia includes, first and foremost, the commitment from the administration with the financial support. And it's very urgent. Every hospital, first and foremost, they need to practice the pre-authorization and feedback, and that means formulary restriction. Then it's very important to monitor and report the AMS outcome, and country-wise and hospital-specific solution for funding and resource shortfalls are urgently need to improve as AMS program in Asian countries. And the final is future studies focusing on outcome data are needed to determine which program core elements contribute to the success of the AMS. program in Asian hospitals. So it's a continuous process where we have to implement, learn lessons, and then correct ourselves so that we can bring in to greater extent, reduce the morbidity and mortality, reduce the cost, and we can preserve the antibiotic for the future generation. With this, I would like to end. And these kits are available for free distribution, I hope, from the uh, Robert's team. You can collect the kit, and feedback from this toolkits, anything need to be included, are welcome. So with that, I would like to end my talk. Thank you very much.